All right, we'll get started for this afternoon. We've got a few lectures to cover. The three lectures we're going to give today will then be what's going to be on your next exam, including what was talked about last week. Okay, so next week's the next test. Today's discussion is going to be on aneurysms and dissections of thoracic and abdominal aorta. We don't really have the time to go into the neurosurgical aneurysms that we need to talk about maybe later down the road. But we don't do that many aneurysm clippings here. We do a lot of thoracic and abdominal aortic repairs. Now, points of discussions, we want to go into the definitions and try to make sure that you know the difference between an aneurysm and a dissection. We're going to go into a little bit of the etiology of aneurysms, signs and symptoms, and treatment. And then we'll talk very briefly on pseudoaneurysms. I think you have to know a little bit of the difference between an aneurysm and a pseudoaneurysm. Then we'll talk about dissections, go into the actual classification process, the etiology, some of the signs and symptoms that you'll see, and treatment protocols for that. And then what happens if the patient ruptures. Now, the usual definition for an aneurysm is a simple one in the sense that it's a weakness in the actual vessel wall. And that usual weakness does not mean there's any kind of injury to the intimal layer at all, or it just means that usually the media is actually weakened over time, and as a consequence, an aneurysm can form one or two kinds. You can get a saccular aneurysm, or you can get a fusiform aneurysm. The saccular aneurysms are usually what most people picture as an aneurysm, because that's the way we usually are taught when we were children about how a bicycle tire kind of blows out. It looks like a saccular aneurysm mostly. Those are usually found in only a low pressure systems or decreased pressure systems. If you had a saccular aneurysm in your aorta, you usually rupture that very quickly. So those are usually not the most common. But if you're looking at peripherally in the brain and in the different systems and the organs, you actually have a higher frequency of saccular aneurysms in comparison to fusiform aneurysms. Fusiform aneurysms is what we usually deal with when we're talking about the aorta. So the actual major vessels are where you see the fusiform aneurysms form. Unfortunately, any kind of aneurysm eventually can either dissect or can fully rupture. If it ruptures, it will bleed into the underlying tissue. If you look at a ruptured aneurysm like a saccular aneurysm, if it ruptures in the brain, you get a massive intracranial hemorrhage, which can be fatal. Dissections, which we'll show you in a few minutes what a picture of that is, it's basically a tear in the vessel wall. So there's a big difference between an aneurysm and a dissection. You can actually have totally normal blood vessels and dissect. Okay? You can also have a person who has an underlying aneurysm already, and then that aneurysm weakens and dissects. Okay? So to make sure that it's a difference in your main thinking is that aneurysm means that the intimal layer is still intact, but once a dissection occurs, you always have to have dissection to the intimal layer first. So the endothelial layer is disrupted, and then blood goes in between the layers. And if it goes all the way through all three layers, the intima, the media, and the externa, then that's considered a rupture. All right, so aneurysms, the main ones we're talking about today is not the saccular ones. We're going to go into fusiforms in a lot more detail. The saccular ones are mostly located in the brain and all the other organs, which have arterioles in them. The fusiform can be classified in aneurysms either usually by their location. Usually we'll call these aneurysms specifically, not by any kind of classification, not like the Baker or Stanford classification. That has to do with dissections. When we're talking aneurysms, we usually just talk about it as a location. So we'll call it as ascending. Yes, sir. Thought it was. Is that on? Yeah. I'm just being quiet today. I can be louder, trust me. All right, I'll try to pick up my voice a little bit. If you're looking at the actual fusiform aneurysms, you're looking at the location, not so much as to a classification system that we'll talk about later on, which has to do with the dissections. The locations for aneurysms are usually identified by the anatomical position of where they're at. So you have in this case the ascending thoracic aneurysm versus a descending aortic aneurysm. Or you can have the abdominal aortic aneurysms, which can either be described as either suprarenal or infrarenal. And that basically indicates to you the position in comparison to the renal arteries. And that is actually a very important classification when you're talking about abdominal aortic aneurysms. You do not want to have, or you want to try to do these as infrarenals. They tend to be less risk. The suprarenals have a much higher risk in the sense of kidney failure after the procedure, as well as total GI organ failure as well. So if you look at the combination, which is rare, thank goodness, is the thoraco-abdominal aneurysms, where you have the aneurysm is usually suprarenal, and it incorporates the descending aorta through the diaphragm. These are very difficult to fix, and these are major operative procedures that are only done in very few centers in the United States because of the increased complication rate. The reason it's such a high complication rate is because you have to make an incision to the diaphragm. And if you make any kind of incision into the diaphragm, that means the person is going to have some kind of diaphragmatic failure post-operatively. So these people usually require long-term ventilatory support, possibly, or they have a lot of other associated complications. So one of those things that you want to do in a center where it does them a lot. Now, going back to a little bit in physiology, back to normal anatomy, is talking about the anatomy of the blood vessels kind of important. You can basically layer out almost all the blood vessels in your body into three intimate areas called the tunica intima, media, and the externa. The intima is also known by most of us as the endothelial layer. It's usually a one-cell layer thick. It's a very important layer in the sense that it protects the blood vessel from the actual shear forces that are running through it. It also is important as releasers of certain kinds of mediators that are either going to be, if you look at the arterioles, they're either vasoconstrict or vasodilate the area. The tunica media will vary depending on where the blood vessel is at, if it's a conducting versus a resistance vessels. This area will have a certain amount of smooth muscle. If you look at the capillary, the tunica media is very, very small because there's no muscle wall at all for the capillary. But every single blood vessel, including the veins, have some degree of muscle except for the capillaries. The tunica externa is a very tough outer layer that protects the blood vessel from rupturing. Depending on which one you're talking about, if you're looking at the conducting vessel, this is very, very thick and it basically adds protection to the aorta from rupturing. But if you go down to the capillary, the tunica externa becomes very thin to allow good perfusion, good diffusion to take place. So sort of where this actual damage is taking place when you're talking about aneurysms, it's usually in the medial layer. The medial layer has some kind of disease process, as well as the external layer has developed a weakness, either a collagen deficiency, or there's actually been mediators that have attacked that area and caused the aneurysm to form. And as you'll see a little later on, what a dissection is, it'll make more sense as endothelial, which is a tunica intima injury that's taking place. Now, if you look at aneurysm has many different causes of what causes it. One of the major ones is hypertension, what is associated with hypertension. The other one is associated with atherosclerosis, which is, of course, associated with smoking and obesity. People can also have collagen deficiency, which is kind of consistent with what I was telling you, where you have a deficiency in the medial and external layer. And you can have an inflammatory process, which we think a lot of aneurysms are formed secondary to some form of inflammatory process. That's a new concept that's coming out, that inflammation is becoming a very important way of trying to eliminate these aneurysm formations. If you can understand what causes an aneurysm at the cellular level, which we have not been able to really understand that in the last 30 years, we're starting to get a little better understanding in the last 5 years, that maybe we can terminate the action and prevent the aneurysm from actually forming in some people that have high risk, like Marfan's patients. There's also, of course, disease processes that are infectious. The most common infection that causes aneurysm formation is syphilis. And if you look at that, this actual picture, this is a syphilitic abdominal, thoracic aortic aneurysm that, of course, has gone on to rupture, and the patient passed away from this process. But this is actually what syphilis will look like. There's also trauma that's associated with formation of aneurysms, and that's usually from deceleration injuries. This will present usually several years after a traumatic injury. Usually, if you look at the patient's history, the patient had multiple rib fractures, and nobody really picked up that they had an aortic dissection at the time that repaired itself, or just damaged the intimal, the medial layer, enough to cause aneurysm to form over time. Now, the mechanisms of the actual aneurysm formation are thought to be related to nitric oxide, is one of the latest findings, especially the inflammatory mediated processes where you have either an ongoing infection or some kind of medial injury, and as a consequence there's macrophage release of increasing levels of nitric oxide with oxygen, which causes free radical formation, and eventually develops a destruction of the intact blood vessel and starts losing the vessel structural integrity. And as a consequence, the actual blood vessel will develop an aneurysm, and eventually, if you don't repair it or if left to time, it will burst. There's also a feeling that there's a certain genetic predisposition, such as Marfan syndrome. There's also collagen deficiencies such as Ehlers-Danlos syndrome, or some patients that have presentations with bicuspid aortic valves also have an increased risk factor for developing aortic aneurysms. The other risk factors that also increase this formation are things like systemic hypertension, pregnancy, increase in lipid levels, and smoking. And that is thought to cause an induction and activation of certain kinds of proteolytic enzymes, which cause a breakdown in the extracellular matrix, eventually cause an increased inflammatory response. This continues to sort of revolve on itself and make the eventual weakness in the wall. If you increase the shear stress on the aortic wall, you may actually then cause more injury, and eventually there's an increase in formation and expansion of these blood vessels, which eventually leads to death and rupturing. The signs and symptoms of aneurysms will depend on the normal anatomy, about the underlying structures that are next to it. If you look at the symptoms that people get when they develop, let's say, aneurysms of the aortic arch, they'll get tracheal inspiratory stridor because of the actual compression. If you look at the surrounding structure next to that, the descending aorta is also the esophagus. So some people will start getting dysphagia from when they eat food that's large. So liquids are not a problem, but when they start eating, regular food, they feel like they can't swallow it and can't keep it down. Sometimes you'll see them regurgitate back. Usually that's a very severe degree of descending aortic aneurysm. The other thing that's very commonly presented is as laryngeal nerve, you get hoarseness. Why is that? And the answer has to do with the way the actual nerve runs. If you look at the left vagus nerve comes down, and that's what actually forms the left recurrent laryngeal nerve. It actually, as it travels downwards, it wraps around the portion of the aortic arch. So if you have an aneurysm that forms here, and if it develops compression, you'll lose your left recurrent laryngeal nerve, and the person will develop hoarseness. Okay? The right recurrent laryngeal nerve is very rarely involved because it's up in the right subclavian artery, but actually rotates around. So if you get an aneurysm formation of the ascending aorta, which then involves the innominate artery and involves the right subclavian artery, then you can get compressions and you can get symptoms of hoarseness from that as well. But most of the symptoms that we see, especially if a patient is dissecting and all of a sudden develops hoarseness in the emergency room, that's a bad sign. That means you have a descending abdominal aortic, thoracic aortic dissection. So look for that as well. If the aneurysm compresses or gets involved in the carotids, then the person may have a stroke. If it if it travels downwards and begins to include the coronary vessels, you can also get occlusion including MI and ischemia. And we'll talk about a little later about what can happen once the aneurysm gets big enough. It can actually dissect, and it can cause tamponade and acute AI. But that's more of a due to dissection. It's not with most of the time with aneurysms. This is, again, a three-dimensional picture of what the heart and the aorta looks like in comparison to the heart and the underlying structures. So something, this is good to review if you have time. You understand the differences between the ascending aorta, the aortic arch, and the descending aorta, and where it lies in the chest. It makes a difference to know that because we approach this in two different approaches. If we do ascending aortic aneurysms, arch aneurysm repairs, we're going through the sternum. If we're doing a descending aortic aneurysm repair, we're going through the thoracotomy procedure, which means we go through the side. Okay, so you have to sort of know where the underlying structures are at in comparison to what we have to do. Diagnosis is usually done, sometimes we'll be diagnosed with chest x-ray. Usually that's harder to do because you have to have a high incidence of suspicion. You have to look for a widened mediastinum. You'll see increase in vascular diameter. CAT scan usually is the best way that people pick up, especially what's called a spiral CT is usually the way we're done now. Spiral CTs can be done in 30 to 40 seconds, versus in the old days when I was first starting out, it would take a CT, it would take 30 minutes, and a lot of patients died in the CT scan when we were doing dissection exams. Now they're done so quickly that it's not a problem most of the time. Echocardiogram is another thing to consider, especially TEE. TEE is kind of very nice to see the ascending aorta and descending aortic aneurysms, but they have a very hard time seeing the aneurysms inside the actual arch. The reason that is the arch is right next to the trachea, and the trachea sort of gets in the way from the echo, and you can't pick up very well the extension into the aortic arch. Some people use angiograms. In this country, we've pretty much gone away from that. The biggest problem with angiograms is that mortality rates are around 5%, and it could be higher if you have a dissection going on. And you may actually induce the dissection with doing an angiogram somebody who has a large aneurysm. The other issue with an angiogram is that it only tells you luminal size, which means it does not tell you true diameter. Okay, an aneurysm can actually be very wide, and the intralumen can actually appear normal. Okay, because what ends up happening with an aneurysm is that you get the intima, and then you get a plaque that forms inside, and that plaque sort of takes up the space. So the aorta will actually look normal when you do the angiographic studies. It may not pick it up. Yes?
So if somebody comes in and it's an emergency, like a abdominal aneurysm or whatever, does he need to do a quick chest x-ray?
Well, if you're looking for different things, usually for aneurysms, most people don't present with any symptoms except they're kind of mild, like I talked about before. So most aneurysms that present are elective, something you don't come in for the emergency room with. People that actually move from aneurysm to dissection, that's when they usually come into the emergency room. Usually they come in for severe pain, so they come in for different reasons. If it's a thoracic, a chest x-ray can sometimes pick it up. But if you really have severe degree of chest pain like that, a spiral CT is really the best way to diagnose this rapidly. If you have an abdominal pain that's severe, which is consistent with abdominal aortic dissection, then also a spiral CT would also show you a good diagnosis. So both of them would be adequate for that. Okay? What we do is when we look at TEEs, we look at the actual aortic diameter. We knew that different areas of the aorta have slightly different sizes. And as you get down further, which is where our viewing area is, down in here, usually it's around 4 centimeters is what you should expect as the maximal diameter that you should see. And we can actually measure it with the TEE. Now there's different treatments for aneurysms. Again, most of the people that present with aneurysms are usually asymptomatic or minorly symptomatic, and it depends on the size of the aneurysm that determines treatment choices that you have. If you have a small aneurysm that's not in the brain or anything like that, then if you're looking at fusiform, diet control, cessation of smoking, and trying to figure out the inhibition of aneurysm mediators, there's actually some thought that maybe giving people ACE inhibitors with this disease will actually prevent or decrease the expansion of the aneurysm formation. The other thing that's also important for medical treatment of aneurysms is hypertension control. Specifically, not so much hypertension in the sense of pressure, but actually the pulsatile wave that matters. Because the greater the number of pulsations you have, with the greater amount of shear force you have, the more likely it is to move on to either a dissection or to rupture. So the way we do that is we want to maintain a lower heart rate as possible. So usually these people are placed on beta blockers. And the other thing that's important is to decrease the degree of contractility that this person is putting out, which is also consistent with giving them beta blockers. If you give this person a reduction of afterload, you're actually increasing their shear force effort. The reason that's happening is if you give somebody nitroprusside, let's say, and you don't give them a beta blocker ahead of time, what's a normal reaction to the heart to a decrease in systemic vascular resistance? Increase in heart rate. So usually you get a tachycardia with it, which increases the number of pulse waves that are being generated, and that is more likely to tear down the aortic wall. So you really want to keep very tight beta control on these patients. And then if you want to consider reducing their afterload, that's fine, but do it kind of gradually. It's actually more important to decrease the contractility, decrease the heart rate, and sometimes just decreasing the preload does most of the job. If you're looking at aneurysms in the brain, which I'm not talking about a lot in this discussion, then you've got to do also consideration of vasospasm control, such as calcium channel blockers, such as nifedipine, are very helpful in preventing vasospasm in the brain. When you're talking about the aorta and stuff like that, vasospasm is really not important. What are your interventions that you have available to you for aneurysms? It depends on the degree of how big the aneurysm is and the location of it. If you have an aneurysm in your brain, you don't want to sit there and wait for it to rupture. It would be massively bad. Okay, so usually for those, we actually will clip them. Okay, we'll take them to the operating room and clip them. The new treatments have now moved on to doing what's called occlusion and bypass, which those are rarely done, where they actually will basically occlude the artery going to that area and do a bypass graft over it. That's not done very often. The more recent things that caught most people's eyes, at least interest, is the endovascular embolization and coiling, especially for very difficult aneurysms to get to in the brain. What they'll actually do is they'll put a wire inside of it and thread it over under cerebral angiograms, and they'll thread this wire and put it like a ball of yarn inside of it, which increases thrombus formation, and it basically forms a thrombus and it occludes. And then the aneurysm tends not to rupture. Okay? This is a good thinking process in the sense that if you don't have to go into the brain and clip these things, I think it would be better for the patient as long as it doesn't rupture, which is always a risk of doing these. As you can imagine, the clip means that the surgeon has to be directly under visualization, and when we talk a little bit about neurosurgery, we'll come back to that. Okay? And the other thing that people are doing is they're stenting these things. They're putting a stent right by it and basically occluding the aneurysm at that point. As for the surgical treatment, that's what we usually call surgical intervention is grafting. Grafting means we actually replace the aneurysm with a Gore-Tex graft, okay? Or we do now, the new process is putting stents. And stents basically reinforce the wall and protect it from rupturing. You're not really fixing the aneurysm, you're just basically internally putting in a stent to prevent it from dissecting or rupturing later down the road. Okay? This is a much better procedure for complication rate stenting is. Stents within 6 months will re-endothelialize, okay? So you will not be able to tell the actual vessel, if you look at it internally, than from surrounding blood vessel. It looks totally the same after about 6 months. The other thing that's cool about stenting is that the risk of complications goes way down because you're not making any big surgical incisions. You're going through the skin, and you're actually doing it with radiographic methods, and you're actually using x-rays to find the location, so you're not having to make major incisions on the patient. Some of these patients will actually go home 2 days later or 1 day after a procedure, which is pretty impressive. If you did these kind of procedures with the open grafting repair, you're looking at least a week or two in the hospital with a huge complication rate associated with it. So stenting may be the future and doesn't mean that we're going to go away. Trust me. When things go bad, they go bad in a hurry. Okay? The first stent that I ever saw done was a disaster. We were told to go down to radiology to give them a hand. This is they were going to do an abdominal aortic aneurysm stenting. Patient was stable. Said, it's going to be an easy procedure. We do it under local. And I said, okay, do you need anything? I said, no, just put in a 20-gauge IV. That's all you need for sedation, and that's all we did. So we have a 20-gauge IV in this patient. I said, this is really not a good idea. I don't like being away from the OR. We don't have no monitors. We have simple monitors. We have nothing. We have no A-lines, nothing. And in the middle of the process, the surgeon said, oops. And oops meant that the abdominal aortic aneurysm went from an aneurysm to a rupture in the radiology suite, which was 3 floors away from the OR. So you can imagine that didn't go very well. So, and we had a 20-gauge IV. It was very good, interesting next 30 minutes. But we eventually did get him to the OR. We did cross-clamp his aorta, but unfortunately he didn't make it. It was too long. And after that, they made the protocol to do these where? In the OR. Okay, and that's where they're being done nowadays too. If you ever get told, this like I was told, these things are fine. These are easy things, no complication rates. They're basically smoking big ganja. So don't believe them. Okay. Anytime you're playing with the major blood vessels, be prepared. It's always better to be prepared because when the disaster happens, it's like no big deal. Versus if you're unprepared, it's really a disaster. Okay, so ultimately, think ahead. Now, unfortunately, due to catheterizations, one of the complications of catheterizations is that you do rupture the blood vessel. I mean, you do enter it with a cannula. And one of the things that can happen after you decannulate is that the blood can actually extravasate out of the blood vessel and start forming an encapsulated blood clot that's around the actual artery. This is a pseudoaneurysm is actually a true rupture. Okay, it's a rupture usually induced by a cannula or some kind of mechanical device, but also a pseudoaneurysm can actually form also from an aneurysm that has actually ruptured. Okay. Now, a pseudoaneurysm, though, normally is a normal artery. So usually when you look at it under ultrasound, the artery looks completely normal, like you see on here. This is an ultrasound device that's looking at it. And you actually see the blood vessels completely normal. It has a neck, which means an entrance into the blood vessel, and its surrounding tissue now has formed a pseudocapsule. Okay? This is not an aneurysm. Okay? These are very, very dangerous. Do not, it's because you see here pseudoaneurysm, say, it's not a big deal. Actually, it's a very big deal because it's a ruptured blood vessel. Okay? And it depends on where it's at. If it's the iliac artery, the femoral artery, it can really bleed, and you can lose somebody from it. Okay? So if you hear somebody's going to do a pseudoaneurysm repair under local anesthesia, they can do that. That's fine, but you better have good IVs in place, and you better have an A-line in place because when they hit these things, they can bleed out on you. And if they lose vascular control, the next vascular control is the aorta, which means it's intra-abdominal, okay, which means they're going to have to cut the belly open in a hurry. You might have to convert that person from a sedation to a general anesthetic in a heartbeat. Okay, so just be prepared about that. So somebody asked me this about 2 months ago, what a pseudoaneurysm was, and I decided to put this in your slides so it makes it easier for you guys next time. Now let's go on to the next topic, which is dissections. Dissections are either occurring in normal blood vessels, or it has a higher predilection in areas that have aneurysms. Okay? The reason that there's a higher incidence in aneurysms is that the vessel walls become thinner, and the intimal layer becomes stretched. As the aneurysm gets bigger and bigger, the intimal layer, which is endothelial cells, just get pulled apart almost. Once a blood vessel, what's in the endothelial layer, gets pulled apart, it produces a tear. Okay? And the way I want you to think about a blood vessel is think about it as 3 socks. The first innermost sock is made out of silk. The next layer you have on top of that is a cotton sock that's heavy. And then the next layer above that is, let's say, made out of parachute cord, heavy duty, very high tensile strength sock. Okay? And normally these are all together, so you can't tell that there's a layering effect. But what happens with a tear or dissection is that the intimal sock, which is the innermost very thin sock, tears open. And then it has the opportunity for blood to start pouring in between the layers. As it begins to pour into the layers, the blood basically goes all the way around the intimal layer and the medial layer possibly. And what you're left with is now blood sausage with the Anyway, so the Bakey's classification I think is a little bit nicer. Also, I was taught in the East Coast of the United States, so I tend to use the DeBakey more so. The reason I like it is because it talks about type 2 separately from type 1, because that's more associated with Marfan syndrome. Okay? So Marfan syndrome tends to be isolated into the ascending aorta and kind of makes it a little bit more manageable. It's still complicated to repair these, and it's very difficult to manage clinically, especially to keep these people alive. If you have a choice between the two, the better one of the two is to have a descending aneurysm with a descending dissection, as long as it's gotten to very rapidly. Yes? At Stanford, that's what they say. They just say if you have it in the ascending aorta, it's considered A. Even if it dissects beyond that, I know the book says it a little bit differently, but most people, as soon as they say this, the intimal tears in the ascending aorta, they're considered a type A. A for ascending, B for descending. That's how they look at it. Okay? I think the weaknesses to any of these things is, of course, that nobody ever follows the same drawing. Okay? So this is the 3 DeBakey classification, the way we see it, 1, 2, and 3. Okay? Now, dissections of the ascending thoracic aorta, also considered the DeBakey 1 and 2, or Stanford A, are usually found in middle-aged people. That's when they usually present. The big problem with them is that you get different kinds of symptoms depending on where the dissection is going. If the dissection goes downwards towards the heart itself, it may actually dissect into the pericardium and cause cardiac tamponade. Okay? And then these people have cardiac tamponade physiology. Now, if you have a choice between what's going to kill you faster, a dissection or a tamponade, the answer is tamponade is going to kill you first. So this is one of the few examples of what I would tell you that don't slow down the heart. If you slow down the heart with a beta blocker, and if it's a person with tamponade, game will be over before the case is even started. Okay? So complicated problem to say the least, but you got to be sort of prepared ahead of time to think about this so you sort of know what you're walking into. The other thing that also occurs when the dissection begins to go downwards towards the heart is it goes right into the aortic valve itself and can actually cause the aortic valve to become completely incompetent. Okay? And you get massive AI. Okay? With a massive AI, you get massive dilation of the heart with massive congestive heart failure presenting very quickly. So sometimes these people are hypoxemic now and in failure. Worst case scenario is if it dissects into the coronary blood vessels. Now the coronaries are involved, which means that you're going to have ischemia, MI, and a very malignant arrhythmias at that point. And that which usually kills people, they go into VTAC. A lot of times, most of the time that I've seen in these cases is they present with it going upwards into the arch. Okay? Although not always. I saw, like I guess the other day, about a year and a half ago, we saw one that went down into the aorta. I've actually got a video of it. I should put it on there. But, that actually showed the AI was wide open and we had a tamponade on top of it all. So, and ischemia. So a little bit of all, every single one. The guy survived it all, in spite of everything that he was trying to do. but he did survive it and actually left the hospital. If you dissect up into the arch arteries, you can get strokes, TIAs, you can get ischemia of the upper extremities as well. But usually the most bad things that happen is, of course, the strokes. Well, how we actually treat this is actually not a joke. It's a very complicated procedure involving us replacing the aorta, the ascending aorta. Even though it dissects posteriorly down the descending aorta, a lot of times it's a type 1, we don't fix that portion. All we do is we just take where the intimal tear is at and basically resect that. In this example they gave you here is that intimal tear is not involving the valves themselves, so all they've done is they've taken the vascular prosthesis and cross-clamped the aorta above and below and then replaced it. Now, that sounds pretty simple, but it's actually pretty complicated in the sense that you cannot get any kind of blood supply to the brain. So these people will actually have to be put on circulatory arrest for a prolonged period of time. These people are considered basically clinically dead when we're doing this. And there's actually ways we actually do this to keep people alive. Now, if it's really, really bad and it dissects downwards, we have new grafts that actually have the actual aortic valve as already incorporated into the actual prosthesis. So we can actually replace the valve at the same time that we're replacing the aortic valve. It really saves a lot of time and makes it a lot easier technically to do it. Yes? Sorry, I missed the question. It drops it. It drops it. And actually, coronary perfusion can be a problem after these procedures because the rigidity of the aorta, the compliance of the aorta is gone after you put these grafts in. The Gore-Tex grafts are able to have some degree of compliance, so they do rebound back a little bit. So they're not so bad that you go to zero diastolic pressure. Okay? If you put a rigid pipe into somebody, which is the original thought that was done in the 1920s, 1930s, all the dogs died immediately within like the third heartbeat. So that failed miserably, so they had to go find something else. What eventually they came up with was the Gore-Tex. The Gore-Tex does give, and it gives you a little bit of rebound, but it's not like the aorta. As a consequence, your diastolic pressure tends to be lower than it should be. The other thing that if you have to, when you have to replace the aortic root, which is even worse, that's when you have to do the valve and the aortic root. You also have to re-anastomose the coronary arteries back to the graft. And now it's not at the normal, see the aortic bulb down here, it's got a nice shape to it, which allows blood flow to come in at high flows, okay? Versus if you're putting in a Gore-Tex, it's at a 90-degree angle. So the blood vessel is coming in at an angle and makes it more difficult for resistance becomes a bigger factor. So sometimes you get ischemia from that as well. But at that point, if you survive all this, you're incredibly lucky. Okay? These are big, big procedures. What's that? Antihypertensive, you mean? No. 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 There's no tissue that you're rejecting. It's just graft. Yeah, it's a foreign body. And the cool thing about vascular grafts like Gore-Tex is they grow back. The endothelial wall will actually grow back. If you ever want to hear a history of how grafts were developed, it's really fascinating if you have the time. But if the way you think about it is they had injuries. The reason World War I started was because of grafts, the lack of them, okay, and the lack of cross clamps. The prince that got shot in World War I that caused the initiation of World War I had a femoral artery injury, something that we would fix easily nowadays, and it's not a big deal. We could cross clamp it and stop the hemorrhaging almost very quickly. And these cross clamps, which is what I was just going to talk about, were actually developed as a consequence of this. Because people could not, the normal clamps in pre-World War I would cut right through the blood vessel. But we actually developed these kind of specialized alligator clamps. If you look at them very carefully, they actually have like little teeth on them, but they're not sharp, and they just compress the vessel and prevent the injury to the vessel itself. But all these different kinds of clamps are very important for survival of doing these. The amount of technical expertise that we learned from the 1920s all the way to the 1960s was massive. And it was just simple clamps, things that we didn't have. And then Gore-Tex came on board simply because people kept trying different kinds of material. And they would actually go to the hardware store and kept buying sheets of cloth, and then they would bring it in and try it out on either animals or they tried it on humans after the animal studies seemed to work. And what actually found out worked was Gore-Tex. So, and Gore-Tex is, if you look at it, it's just basically a cloth that has a matrix in it. And what's interesting about it is after a few months is that the endothelial layer will line it and will basically harbor living cells. So it acts like a basement membrane, and it works very well. There's new things that are coming down the pike, which are called extracellular matrix proteins, which are made from pig's bladders, also called pixie dust. You guys heard about that at all? They're using in the military right now. They're taking these grafts and putting them in, and fingers and toes are actually coming back and they're regrowing. So cool stuff that may be down the road. We might be able to regenerate some stuff. Yes? I think that's the same stuff. But it's now, we're actually regenerating tissue again. So it's something we never thought that was possible. So even though it was thought to be science fiction when I was growing up, now it's like, it's possible. Anyways, management of anesthesia for this kind of procedure, you're looking at preoperatively do a left radial A-line for these cerebral monitoring is pretty important because you want to make sure that this person has no EEG activity. So you're trying to make them isoelectric before you put them in cardiovascular arrest and circulatory arrest. Some people use Dopplers. I don't personally use them. It's they're moving around too much. It makes too much noise in the room. So instead we use cerebral oximetries or we use BIS. This is a sternotomy approach. The induction is critical. If you can get them past the induction phase and not kill them in the process, it's pretty critical. You want to make sure that the person's not hypertensive on induction and not tachycardic. So usually I use heavy doses of beta blockers, and then I will consider using a normal cardiac induction. If it's a dissection and it's an acute injury, then you've got to go with etomidate and succinylcholine and intubate them quickly. But at the same time, you get them beta blockers up front so you don't get that tachycardia and rupture the aneurysm dissection. Normal intubation in the sense that it's a single lumen tube that you put in these people. Intraoperative monitoring, let me finish this last slide, then we'll stop and we'll start the next hour. Cross clamping is pretty important as position. The cross clamp where it's going is usually above where the tear is at, so it's right here, and then you get no blood supply to the brain. Some people have actually tried to do a subclavian artery perfusion. The problem with it is it sometimes doesn't necessarily work. So what we've actually moved to is we know that we're not going to perfuse these people cerebrally because we can do what's called circ arrest. So this person has to have some form of cerebral protection. The way we shut down the brain is pretty important. The way we actually check that the brain's down in the sense of cells is look at the EEG activity. We make them isoelectric. So we give them chemicals, we give them drugs to make them isoelectric. Versed will do it. Pentothal will do it. So all the barbiturates, all the GABA agents can do it. So high-dose Diprivan will do it as well, supposedly. Not as well as Versed or Pentothal. The other thing that's important is to make sure that you don't have high glucoses during these times. High glucose will then provide cellular energy, which increases cerebral activity of the brain cell, which you don't want it to do at that time. So you want to keep that down to low levels or normal levels as possible. And then you want to sort of protect the brain from free radical formation. And so a lot of us will give mannitol right before we go on to cerebral arrest. And so we usually give high doses, usually 2 grams of mannitol to make sure that there's plenty of mannitol around to be a free radical scavenger to soak up some of the free radicals that the brain's going to produce. Then we do what's called deep hypothermic circulatory arrest, which means we put the patient into a temperature of 19 degrees Celsius. They'll do a fem-pem bypass, and they'll make the person hypothermic. They'll drive them down to 19 degrees Celsius. And then once we do that, then the heart stops usually, and then we're in deep hypothermic arrest. During that time, the patient is clinically dead. Okay? And you have nothing you can do except sit and wait. You don't have to worry about the person having any awareness, because at 19 degrees Celsius, your brain has no form of memory at all. Okay? So, and you will see no isoelectric activity. There will be abyss of zero. That's what you want. The other thing that you want to sort of consider is do spinal cord protection and kidney protection, but those are secondary concerns in comparison to the brain. If you can keep the brain alive, everything else will stay with you, usually. Okay? And fem-pem bypass is pretty critical to keep the hypothermic event going. Postoperative management is postoperative bleeding is a big problem. Prevention of vascular integrity is pretty important. You don't want to get the blood pressure too high, so usually we'll give beta blockers to make sure that we manage that properly. Watch your arrhythmias, especially when you're coming through the hypothermia backup. If you late consequences are lack of perfusion to the brain, so some people never wake up, and you have a brain dead patient on your hands, which is pretty sad. And the other thing that can happen is you can embolization from air, atherosclerosis, or from thromboembolism that can form during the procedure. And usually if you start having brain dysfunction, you usually have other organ dysfunction as well. So this is a procedure where you want a really good surgeon. I mean, it doesn't matter most of the time. You want a good surgeon for everything, but I mean, this is a surgeon where you want a great surgeon. We have some of the great surgeons here, so it's not something I could say very commonly. Guys can get this done in about 45 minutes here, which is amazing. I've seen them do an aortic arch repair with 32 minutes, which is moving. Yes? As long as you need to. You can't go back on until you get the aorta repaired. So, you know, that's why I'm telling you the preferable time is 30 minutes or less. But it's very few individuals that I've ever seen that can do it under 30 minutes, except for the descending aorta. Most people can do it under 30 minutes. For the ascending aorta, you're looking at a lot more suturing. And if you're looking at the aortic valve replacement at the same time, it's more time. So 45 minutes and under is considered good. Yes? Right around 21 to 22. Once you get them 19, they're usually isoelectric in the heart too. The heart just sort of stops. It goes systolic. So, interesting thing to watch. Okay? It's coming out of it. It's a pain. But that's what the fem-pem bypass will help you, because it will help rewarm the patient. The way this was done originally, patients were taken into an ice bath and dunked and left underneath the ice. Once they got to 19 degrees, then they pulled them out. They were intubated under general anesthesia, but they were basically ice-bound. That's what was done before World War II. That's how they did actual aneurysm repairs in those days. They didn't have any bypass machines. So, a lot of things have changed. All right, let's go on to the next section, which is dissections of the descending aorta. Descending thoracic aorta. This is also known as DeBakey type 3 or Stanford type B. Most people usually present are asymptomatic, which is really scary. Most of these are decelerating injuries, so they usually have the car accident or something that causes rapid decelerations. Parachute accidents will also do it. Patients that are pilots will have rapid deceleration injuries will also do it. High Gs can do it. But usually the person is a little bit asymptomatic sometimes. The other thing you also have associated with is myocardial contusions. Once the dissection starts getting big enough, it becomes asymptomatic to becoming slightly symptomatic, where the person starts having some back discomfort. And then when it gets really, really bad, it'll get to full-blown back pain, but that's usually right before they rupture. So patients usually start complaining of severe pain right before they rupture. Now you can see this dissection is extending all the way down into the abdomen, and you don't fix it by going all the way down. You just fix the thoracic dissection up here. Okay. Now because it is a descending, it's retro behind the heart. So it's not, the aorta itself is behind the heart, and it's against the vertebral bodies. Okay, so you repair this one through a thoracotomy, and you repair it usually through a left thoracotomy, of course. Okay, now why do I say just left? It's not always left. Some people actually have dextrocardia, and they have the actual blood vessels all on the other side. Very, very rare. Have I ever seen it? Nope. Theoretically possible? Yep. But most likely not to ever see it in your career. But I've never seen it in my career, but that's something I always think about in the back of my mind. I hope I don't screw it up if it ever comes in like that, which would be a strange one to be ready for. In that case, you'd have to be putting the person in right lateral decubitus, left lateral decubitus to do that procedure. Now, the presentation is time to injury to OR is critical. This follows a very interesting rule called the 50% death rate. Okay? When usually people present with this in the field, 50% are dead within 15 minutes. Okay? That's within the first 15 minutes of the injury. So these are classic patients that come out of the car and say, oh, I can't believe I survived. The other person's dead in the other car. Usually they've hit head on. And they walk around for a few minutes and all of a sudden they just drop. And then they're dead. And that's a ruptured thoracic dissection usually. Now, if 50% survive, what happens to them? Well, if you get to them within the first hour, 50% of those will be dead in the first hour. So 50% of 50% means that 75% of patients will be dead within the first hour of presentation. So these people will actually come into the ER and they'll look at you and all of a sudden they have severe pain and all of a sudden go out. Or some of them will just go out without even telling you anything and they have no blood pressure. Okay? And that means they progress into rupture. Now, if they go into rupture at all, it's a waste of time to do anything. It's one of the few things that if you know the diagnosis and you know you're going to the OR and the person ruptures in transport, game over. Okay? You just do not have the time to bring the patient into the room, put the person in the lateral position, intubate them, get everything done that you need to get done so the surgery can be a success for them to have survival of their brain. So in that case, you just divert and say, game's over. Do not take him to the operating room. Okay? That may sound harsh, but I can tell you, I've tried it. I've done it at least 7 times and 100% mortality rate every time. It was just a waste of blood products and personnel. So if, let's say you do get him in the OR, what happens if you don't get him in the OR for the first hour? Then you lose another 50% of that. So in other words, 12.5% people more be dead. So you have an 87.5% mortality rate in 2 hours. So you really have to get them in there quickly. So if you can get them in from the accident scene to the OR under an hour, you're now working around 12.5% of the survivors that are going to make it. Okay? Of that 12.5%, 50% will die on the table. Okay, so this is not a joke procedure. Okay, and if you get them out of the room, 50% of those will go on to have an uncomplicated course and actually survive. So you're looking at about 3% of all patients with that thoracic aneurysms will actually survive and walk out of the hospital. The other 3% that did survive will have severe complications, paraplegia being one of them. Okay? So conservative medical management is a waste of time. Don't. It's a surgical disease. Is it a bridge to medical surgical? Yeah, but you better be doing it quick. And what you're trying to do with medical management is you're decreasing the extension of the dissection by maintaining a control of the blood pressure. The way you do that is basically controlling heart rate. That's really the most important thing. You decrease the pulse wave activity. Usually I give heavy doses of beta blockers to these patients. I usually have them at a heart rate of 50 or less. One person was looking at me one day and was like, you have the heart rates at 40. I'm going like, yep, and the blood pressure is 105. That's exactly where we want them. Okay? Contractility is really low at that point, which is what you want. You don't want shear forces. If we intubated, the heart rate went from 45 to 51. Perfect induction. Okay? That's what you want. You don't want the heart rate to go from 50 to 102 when you put the laryngoscope blade, because I'll tell you, when it hits 102, you won't have an aorta left. Okay, so you want to have very tight beta blocker control of these patients. Surgical intervention is one of the only things that keep this person alive. And The critical part of this procedure is keep it under 30 minutes. 30 minutes is the critical time of when they put the cross clamp to the uncross clamp. Okay, that's the critical phase. The surgical options that you have is two nowadays. We only had one before, which was graft placement. Graft placement means that we actually cut open the aorta, replace it with a Gore-Tex graft, and close it back up. Okay. Usually what we do is we leave the aneurysm or the dissection already in place. We just cut away. We don't cut it away completely in the sense that we cover it back up with that structure. So the Gore-Tex will not normally be visible like in this picture. You actually see the Gore-Tex will be completely incorporated into the blood vessel. Stent placement is the other consideration. Okay, stent placement means that the stent is now covering the dissection, and if this is an aneurysm, this is what it's showing here, but the dissection will also cover it. The problem with stent placement I see, and still is an issue, is that a lot of these dissections are really close to the left subclavian artery, and the stent can actually go over the top of that, and you'll lose blood flow to the arm. Bad complication. So I still think grafting is going to be here to stay for a while. Now, management of anesthesia, speed is really important, and monitoring is really important. Put as many monitors as you can, as fast as you can. And usually it's put in 2 big IVs, 14 gauge IVs minimum. Put in a cordis or a double cordis, which is what we usually do to make sure that we can give blood transfusions back quickly. Don't put a quad lumen in, it's a waste of time. So just put in a cordis. Usually a trauma cordis, which is a 9.5 French cordis, which is huge. Then you can put in swan gans if you can, slip it in quickly. We usually do the right radial A line because the left usually will go out when they put the clamp. The clamp is so close to the left subclavian artery that it'll knock out the left radial. What I do is put bilateral pulse oximetries in these people so I can monitor both arms, make sure that both are being perfused. The good thing about this is you're still going to perfuse the brain. So you're not going to get cerebral ischemia normally with this. Okay? But the rest of the body is going to get ischemic. And I'll show you what I'm worried about here in a minute. Femoral A lines a lot of times are put in just to know what the distal pressures are doing, so you know what the lower extremities are doing. And you can draw blood gases from it as well, so you can monitor the degree of acidosis that's taking place below the cross clamp. The induction, of course, the prevention of rupture is a critical part of it, and usually all these people are full stomachs. Usually this occurs right around 4 or 5 o'clock in the afternoon. All the dissections that I've taken care of are around 5 o'clock in the afternoon. Okay. Reason being is that 4 o'clock is when people go home after work. That's when they get car accidents. The reason it's at 4 o'clock is because that's when the EMS services are at their peak, and they're more likely to get you quickly out of there and get you back in to the hospital quickly. And you have plenty of personnel that's awake, pretty sharp, ready to go. So you have the best chance of surviving if you get that car accident at that time. Where it's really bad is if you're at 2 o'clock in the morning, you get a car accident because you're drunk. You're not able to tell people you have pain. You come in, kind of out of it. Dissection's already evolving, and then it ruptures before you know it. Okay, so a lot of times it's missed at 2 o'clock in the morning. So usually we don't get these at 2 o'clock in the morning. Anyway, so one of the things you want to do is airway, is that you want to put a double lumen tube in these people if possible. It's really preferable not to do a double lumen tube because most people are considered full stomachs. So you want to do instead a single lumen tube, but in a way to be able to isolate the left lung and collapse it during the procedure. There's 2 ways of doing it. You can do it the cheapo way. The cheapo way is a Fogarty catheter, which is this. This is a device that's basically a little balloon at the end of a plastic catheter. You just put a normal endotracheal tube in quickly. I've done this at least 3 times in my career, and had a jury rig it because they don't have bronchial blockers. This is the other better way of having it. Bronchial blockers actually come with the system already in place, and you take the fiber optic, look down, and you just manipulate the endotracheal tube until you get the actual catheter to come out, and then you occlude the left main bronchus. So now you can collapse the left lung completely. Okay, but you have to collapse the lung first and then inflate the cuff. Or the Fogarty catheter, what you do is you put a single lumen tube down, and you just pass it down, and then you jury rig it back up through a bronch adapter with tape, and you can seal it. It works. And I've done it. And the third way is to do a double lumen tube. Double lumen tube is great. It's better than any other devices because it allows you to be able to insufflate the lung if you need to. and you can suction out the lungs, both sides. So there's advantages to it. The downside to it is you better be good at putting double lumen tubes in, which a lot of people are not, and it takes too long. And if you're at risk for aspiration, man, it's not the best choice. Okay. You have to transfer the patient into a right lateral decubitus position, which means right side down. The good side about that is that has the most lobes and has the most perfusion, so it gives you the best VQ match. If we had to do it the other opposite side, it'd be disaster. So thank goodness for the aorta being on the left side of your chest. Now, one of the things that you really have to worry about, which is most people don't understand until you really get into this, is understanding the blood supply to the spinal cord. Blood supply to the spinal cord is provided by two areas. One is by the posterior spinal artery and the anterior spinal artery. The posterior spinal artery is provided by portions of the aorta, but usually there have lots of other collateral blood flow that's not so much a worry about. The anterior spinal artery, on the other hand, is supplied by arteries that basically leave the posterior aspect of the aorta. Okay? So when you're having a dissection in that area, what happens to those arteries? They're getting compressed. Okay, so you're losing them. Okay? So, and if you cross clamp above it, you're going to lose the blood supply to that artery. Okay? Now, these intercostal arteries actually bifurcate and eventually go into form the intercostal arteries around each one of your ribs, but it also sends out another artery out of it, which is called the radicular artery. The radicular artery then supplies the anterior spinal artery with its blood flow. Okay? So if you have that, no perfusion goes through that area, then you'll get loss of motor loss, and you get loss of urinary and fecal control, which is pretty severe. So that's it's definitely a changing of you're becoming basically a paraplegic. Okay. Now there's one artery in particular that we get very concerned about, which is called the artery of Adamkiewicz. The artery of Adamkiewicz is unique in the sense that it's a single blood vessel, usually arising in the left side, that provides all the blood flow to the anterior spinal artery. It's much larger than your regular radicular arteries that are coming off. It's like 10 times larger. And what happens to the anterior spinal cord artery right before that area is it narrows down. So below that area is completely dependent on that artery of Adamkiewicz to be patent. If you occlude the artery of Adamkiewicz, that portion of the cord will get ischemic and you will develop paraplegia. Okay? Now, if you look at it, left, 75% of the artery of Adamkiewicz is located in the left side, 25% on the right. If you look at where the location is normally starting for where the artery of Adamkiewicz originates, almost 85% originates from T9 through T12 subsegments. So if you're cross-clamping above that and cross-clamping below that and you do fem-pem bypass, that person should still be okay. But if you have the unlucky person, which has the artery of Adamkiewicz being high, which is at T5 through T8, that's where the cross-clamp's at. And 15% of those patients will develop ischemia of the cord very rapidly. Okay? Even if the cross clamp is removed after 30 minutes, they will still get ischemic because now the graft is now removed all those of the artery of Adamkiewicz out of the system. So in 15% of the patients, even if everything went perfect and you had the time under 30 minutes, you would get paraplegia. Okay? You're playing basically roulette. Okay? You don't know who's coming out paraplegic after this case. Now, if you do it under 30 minutes, then your chance of you, if you're having the 85% artery of Adamkiewicz below that, chance of you having no neurological deficits is very good. If you extend it beyond 1 minute of 30 minutes, your increase of paraplegic rate goes by 50% per minute. So it's bad. 30 minutes is a cutoff. Okay. At 32 minutes, when I was doing a case like this, I lost all blood pressure except for blood pressure went down to 35, with the heart rate stayed fixed. at 62. And what's the first thing you think of when you lose a blood pressure like that? The surgeon took the cross clamps off. So I immediately looked over the top. I said, "Do you take the cross clamps off?" Nope. Okay. No cross clamps came off. And what you're looking at is what's called neurogenic shock. And the person is complete neurogenic shock and is completely vasodilated. And the way you pick up on it is that the heart rate didn't pick up. The heart rate should have picked up, should have gone up on us. And at that point, the beta blocker had been off. We weren't giving any more beta blocker. So the person should have reacted by increasing heart rate, which they didn't. Which also indicates spinal cord ischemia. Okay, because you're knocking out the cardiac accelerator fibers. Okay. So sure enough, this kid woke up 24 years old with paraplegia. And the good thing is he woke up. He was one of the 6% that survived with the 3% major complication rate. Okay. What you do if you have time is you can consider monitoring for spinal ischemia. The way you have to do it is you actually use the motor evoked potentials, not the sensory evoked potentials, because sensory evoked potentials are covered by the posterior spinal arteries, so not a problem most of the time. The anterior spinal artery, on the other hand, is the one you're looking for, so you're looking for motor evoked potentials that are being generated. So it's a little bit more difficult to monitor. Some of the new things that are being done is they'll put intrathecal catheters, which means they'll put a catheter in the spine, and they'll drain some degree of CSF. The reason they're draining CSF is to decrease the intraspinal pressure, so it increases perfusion into that area. The other thing that they're also injecting into the spinal cord is to protect it, is injecting papaverine into it. Okay, papaverine is meat tenderizer. I always thought that was kind of strange that they're injecting that into it, but apparently it protects the spinal cord. I've never personally done it. Usually when you're in this situation, you're moving pretty fast. And if you get a wet tap in this, if you get a bloody tap in this area, it's a nightmare because this person's anticoagulated when you're doing this procedure, so you can get a spinal hematoma from it, which would be the same thing as getting an anterior spinal cord syndrome. So kind of between a rock and a hard place. I still think overall you've got to consider all the risk factors you're dealing with here and do the best you can. If you look at the aneurysms of the abdominal aorta, this is going to go a little bit backwards. We went sort of dissections first in thoracic. Now we're going to go to aneurysms, and then we're going to go back to dissections again. Usually aneurysms of the abdominal aorta is due to atherosclerosis. Usually it's found in males who are greater than the age of 60. It has a lot of family tendency. And we think it's also related to their job. If you're sitting down a long time in your job for long hours, you're actually occluding your femoral arteries, and you're cross-clamping them. If you're a person that wakes up or senses that you've been working on the desk for too long and your legs are asleep, that's not a good sign. That means you've occluded the femoral artery. You may increase your risk of developing clots and increase your risk of developing aneurysms of the aorta if you're doing that often. So if you're doing that often, you should get up off your chair and walk more. Or like some people do is they have different kinds of chairs where they're not allowed to really sit down like we normally do with bending our legs. So there's concerns about it. Human beings are not meant to sit down all day long, and they're meant to walk around most of the time. Even when you're laying down flat, so your femoral arteries are not occluded. Okay? Most of these are when you see them present, they're painless. Okay, this is a nice picture showing you a very large aneurysm. It's actually this guy is thin, that's why you can see it. You can actually see it pulsating on his belly. I've seen one like that, and people said, "Oh, this is really cool." I said, "Don't touch it. You don't need to touch it. You can just sit and watch it." Okay, if you touch it and you press on it real hard, it may actually rupture. So don't do that. Okay. That person, if you're seeing if you see something that's pulsating on the belly wall, it's time to go to the OR. Okay, that's usually a very bad sign, and usually size dictates intervention. If you're less than 5 centimeters, there's a 5% incidence of spontaneous rupture. If you're over 5 centimeters, there's a 70% rupture within a year of spontaneous rupture. Okay, that's pretty high. And the mortality rate is almost 80-90%. The mortality rate if it ruptures is very, very high. Okay, My personal feeling is that if you rupture and you knew that you had an elective abdominal aortic aneurysm and you elected not to get elective surgery, then you should not be given surgery. Your mortality rate's 90%, and you're wasting all that money on 90% of people that should have been fixed beforehand. The mortality rate for doing it, if you're electively done, is around 5%. Big difference, okay? And a lot of times now we can do them under just with stenting, which has even got a lower incidence of mortality rate. So, you know, some people just don't think it out loud. We had one lady that came in, she was 85 years old. She basically said she didn't want it repaired. And then at 86 years of age, her birthday, she ruptured from, I guess, too much of a big party that day. And came in, and her blood pressure was like 62. And by the time we got her in the OR, her blood pressure was 40. And I was looking at the surgeon like, what do you want me to do? She's 86 years old. She's going to die on the table as soon as we give her medicines, you know that. And the surgeon looked at me and said, oh, we've got to try. It's like, okay, all right. We tried, all right. As soon as we gave the induction dose of etomidate, the blood pressure went to 0, and she went asystolic in about 32 seconds. It was like rather impressive. I don't think the etomidate circulated. So I think it was just from the pre-masking, pre-oxygenating the individual. So sometimes you're just doing stupid stuff like that. Okay, and then it was considered what? Considered an intraoperative death. Oh yeah, so it was great. It was like nonstop. The fun just was just going to continue going on for about several weeks for that one. But silly stuff like that, it just doesn't make sense. This is what an aneurysm will look like under angiographic studies sometimes. A lot of times, sometimes you do an angiographic study, the actual aneurysm will actually look normal. The artery wall and all this outer layer here. You see how it looks a little granular out here? You know why it's granular? All that's plaque. Okay, this is a soft plaque because it actually got the dye, went through it into it. But a lot of times the plaque becomes hard like rock. I've actually seen the surgeon open up the aorta, and we were doing it the old way of doing it, which is the putting in the Gore-Tex. And when he opened it up, the scalpel broke. That's how hard the material was inside. Okay, so it can be pretty tough. The other thing is that we use a very special device to scoop out all this atherosclerotic plaque. It's called a spoon. So we take a spoon and scrape it out. It's a big soup spoon. At first I looked at it like, what the heck are you guys doing? You just got that from the cafeteria? They go, yeah, it's our special instrument. And the nurse brings it out like it's a special instrument and gives it to them. You're just losing it. So it really, if you ever had this procedure done, all I can tell you is there was only one question you need to ask. How fast can you do it? Okay, if the surgeon tells you, well, it normally takes 8 hours, my answer to that is run. Run. Find a guy who can do it in 2 to 3 hours. And sometimes vascular surgeons are better, sometimes they're not. And we've had vascular surgeons that take 8 hours to do all these, and every single time it's a disaster. And every single time it's always whose fault? Anesthesia's fault. Geez, can't you wake up the patient better? Why is the person developing renal failure? It's anesthesia's fault. It's all that medicine you're giving them. It has nothing to do with it. It has to do with how long you're not perfusing. Okay. And we have our other surgeons. Most of the guys now can do them pretty fast. But we had some guys here that are actually retired, thank goodness. It would take 8 hours to do this. Our other surgeons would do these in 3 hours and be done. We had actually one of our, I can't say what, we had somebody that I know that had aneurysm repaired, and basically he came in ruptured, which has a 90% mortality rate, and he got it done, and they did the whole procedure in 1.5 hours, skin to close, and that's why he survives to this day. But it doesn't mean he didn't have complications. They went on to having a BKA eventually. So usually this is a bad thing because it's a progression of the disease. But they did get him out of the operating room and he survived. Dissections of the abdominal aortic wall is pretty bad. When that happens, you get acute pain. These usually are very symptomatic because you have so many surrounding visceral structures in there. The person usually goes into hemorrhagic shock. Renal failure can develop very quickly. You get lower extremity shock. Literally, when you see somebody with an abdominal aorta that's ruptured and dissected, they'll have a cutoff line. Their skin will look normal, and then when you look at them, you pull off their shirt, look, and you'll see like a line. And the line is petechial below, and it starts looking blue. And that's how you know you got a rupture, right there. Just looking at the skin will actually tell you there's no perfusion below that area. Okay? The hemorrhaging, if you survive it, is retroperitoneal, and basically lose up to 2.5 liters to 3 liters of blood around it, and it compresses on the aorta and holds it. So now you have this big pulsatile mass. When you get into the belly, you won't get any blood. So you go like, oh, that's not a problem. The surgeon's in there and no big deal. Well, you haven't gotten to the big deal yet. When the surgeon if he doesn't put the cross clamp perfectly on, or he hits the peritoneum and the thing ruptures open, all that 2 liters comes pouring out. So your field of vision goes from from perfect to 0. You can't see anything. And it's pouring out. And it's pulsatile. So you see it squirting everywhere. Okay, I've actually seen one explode to actually hit the roof. Blood dripping everywhere. It's like looked like a horror movie. So sometimes you do get bad things happen. The other thing that can happen too is if the cross clamp is not being done carefully, because sometimes surgeons, they get epinephrine rushes just like we do. They're human beings. They'll get in a rush to get in there, and they'll take the clamp and actually hit the blood vessel, rupturing it, which is really bad. Okay, you sort of want to let them sort of get their hands steady as they're getting in there to slow it down. What I've seen best worked is the guys usually are doing it. They'll take their fingers first, and they'll take the cross clamp, put their cross clamp on their fingers. In other words, they'll put their fingers on the aorta and cross clamp it with the aorta with their fingers, and then they take the clamp above it, and then they clamp it. And that's the best surgeons I've ever seen. They usually do that quickly, and it's over with. The blood pressure stabilizes at that point, and everything's fine until they now have time to repair it. The faster you repair it, the better. It's not like the mortality rate is good. The mortality rate's looking at about 85% of these people will be dead in 30 days if they've dissected and ruptured. Okay, so you really don't want to see that. But almost 80% of them are dead right as soon as you leave the room. So the other 5% are the ones that are late dyers usually. So if you can get them out of the OR, you're pretty good. Okay. Management of anesthesia, high approach is important in the sense that are you doing a retroperitoneal approach, or are you going to do a straight abdominal approach? If you're doing an emergency dissection rupture, you're going straight. If you're doing an aneurysm, some people will do a retroperitoneal approach, which means they take the body and rotate the hip way over, and they make the incision laterally. They come across like a nephrectomy incision. Okay, so you have to watch. The reason that's important is because if they can get too high and knock out your lung. They can enter into the diaphragm, and all of a sudden you got a tension pneumothorax. Versus the straight approach, straight in the belly, you're never going to get into the lung. It's not going to be a problem. Okay? The reason that some people use a retroperitoneal approach is there's less risk of complications associated with it unless you bleed. If the thing ruptures while you're in there to fix an aneurysm, retroperitoneal approach is wanted to death. Very few of the surgeons can actually control the bleeding when it ruptures on them like that. So usually they'll now extend the incision and go intra-abdominal. Then the risk goes way up in complications because now you've cut this way across the belly to get in. So you're now cutting across the muscles instead of going up and down with them. So hopefully you won't see that too much anymore because we're doing grafting a lot more, okay, with stents. Preoperatively, you want to make sure you A-line. You preoperatively monitor these people at the max, have good IV access. Usually we would spend almost an hour getting everything in before we can start these procedures, if they're your aneurysms. If they're dissections, you better be moving at hyper speed. You've got 10 or 15 minutes to get everything in, and put in as much as you can in 15 minutes. First thing to go in is your IVs, second thing goes in is your A-line, third thing goes in is your Swan. Okay? Maintenance is basically, once you get them down, is to try to protect them from the cross clamp. So try to give them mannitol to protect their kidneys, if you can. Most of the time, if you have a complete rupture, you're basically fighting blood pressure. So you're trying to save their life by giving them blood. I would not waste a lot of blood doing that too much. I would give them maybe 1 or 2 units max. The rest would be crystalloid until the surgeon puts a cross clamp on. Because otherwise, guess where all that blood goes? It goes into the field. It's a waste of money. It's waste of products. And it's really a waste of blood products. You only have so much. In a community hospital, you find out it's not like a trauma center. Trauma centers have hundreds of units of blood. A community hospital maybe has 50 units of blood, and that's all you're going to get. You can't waste it. Okay? So you got to be really conservative in your management. So don't give a bunch of blood until you get in there and put the cross clamp on. That's when you give the blood. Because now when the cross clamp's on, you start giving him blood. Okay? Emergence, the biggest problem is when maintenance-wise is when you uncross clamp. That's when the disaster happens. When the cross clamp goes on, the blood pressure basically comes back up, everything stabilizes. But when you take the cross clamp off, it depends on how long the ischemia has been going on. When you take the cross clamp off, what will happen is they'll take the femoral arteries and occlude them for you, and they'll basically take off the aortic clamp first. Okay? So now you'll have your GI tract starts reperfusing. If you've been ischemic for a long period of time, you get a lot of metabolic acidosis going in, a lot of bad things come in, and your actual cardiac output will be suppressed. Okay? The way you fix that is you give blood before you come off cross clamp. Make sure that the hemoglobin is good, like 14, so it acts like a buffer. Okay? Hemoglobin is a good buffer. Okay? So it's going to be a good buffering capacity. And once that cross clamp goes off, then give yourself time if everything's stable. Normally blood pressure should fall by 20 to 30%. So your blood pressure should be like at 140 before the cross clamp comes off to get them down to like 110. If you're starting your blood pressure at 100, when you take the cross clamp off, you're going to be in the 60s or 50s, not somewhere where you want to be. Okay. The second thing you learn over time is that when you take the femoral arteries off, the cross clamps off, you do one at a time, and give it time to recirculate, which is usually about 5 or 10 minutes, and then you take the clamp off. Try to direct the surgeon by saying, look, I got ischemia up here or something else going on. If you're seeing it affect, give yourself a little time by talking to the surgeon so he doesn't take the clamps off all of a sudden. They have a tendency to want to do that, but it's a disaster in our end because we can't stabilize them at that point. Okay? The clamps keep the person alive. An extra 10 minutes is not going to matter in the other leg. Okay? It's going to matter a lot to the heart, though. Once you emerge these people, the answer is keep them intubated. I would not extubate any of these people. They all go to the ICU intubated and monitor to the nth degree to see what kind of bad effects they're going to have to their other organs. Now, if you're doing an aneurysm repair, you can consider doing an epidural for post-op pain. Okay? And what I would recommend you do is if you're doing that, make sure that you don't get any bloody tap. And usually with aneurysm repairs, you can actually extubate this person. For dissections, you don't. But for aneurysm repair, if you got the pain controlled, at the end, you can actually extubate the patient. They do fine. Okay, as long as they're not doing it for 8 to 12 hours. We would put the epidural in, and then at the end of the procedure, when we're getting close, after the cross clamps have been off and everything's stable, and the blood product has been adequately replaced, then we will dose with bupivacaine, 0.25% or less. The reason we're not giving the 0.5 milligrams is because we don't want to see any motor loss. We want to watch for motor loss. If this person wakes up and is not able to move their legs, that's a bad sign, and the surgeon may need to do something about it. Okay? Not that they can do very much sometimes, but at least you know that's not induced by the actual epidural. Okay? If you do have a blood tap when you're doing an epidural, though, case has to get canceled. The reason being is you're going to heparinize the patient during the procedure, and if you enter the epidural vein and you give heparin, you may actually induce a actual epidural hematoma, and the person may actually get paraplegia from that. So that's another reason why you want to pick up on it. Okay, in case you did have a venous tap and didn't know about it, and all of a sudden now you've got you got motor loss, even though you only get less than 0.25% bupivacaine. What you do at that point is you take that patient right now to the MRI scanner. MRI would confirm or not that you have an epidural hematoma. If you had an epidural hematoma, what would you do? Back to the OR, flip them over, laminectomy, open them up. Okay? Bad complication, but you know what? there's risk in everything that we do. Okay, hopefully you'll never be there. All right, this is what an aneurysm looks like. Pretty mean looking, usually pulsating monsters, and they will blow up on you in a hurry. Okay, putting the cross clamp on these things are pretty serious, and like I said to you, usually the surgeon knows what they're doing. They'll be very careful with it and putting the cross clamp nice and easy. Even if they're dissecting, you don't want to see the guy rushing around. Just use your fingers first and then put the clamp on it. It's more controlled. It's when you see the guy who's just grabbed this. It always worries me when I see the surgeon going like this with the clamp opened and they're inserting it like that. And that's where the biggest disasters I've ever seen. They go right to the aorta. Everything blows up. It's just a nightmare. Eventually, all bleeding stops. Okay. Stenting. General versus regional. I would tell you general anesthesia is what I prefer myself because it's at that point you're intubated, everything is secured, you have your IV access, everything's happy, and you got them A-lined. Not a problem. The only problem I have with regional anesthesia is if you get into a ruptured state, now you've got a sympathectomy going, you're in big trouble. Okay, so the only time I'll ever do regional anesthetic for a stent for a surgeon is if I know the surgeon's really, really good and doesn't have any complications. Okay. If the guy's just right off the street, just came off residency training, and he says he can do every single thing if he's God, just came down to earth, and he's full of it, so he's going to be running into all these complications for the first time in his career because he doesn't have Papa Bear watching over him. So make sure that you have this guy on a regional until he's proven otherwise wrong. Okay. Otherwise, I'm not a real fan for regional. This is what the stents actually look like. We actually put them in. Okay. Stents don't go without risk, though. I'm going to show you a picture of it in a minute. And you can see this is atherosclerotic plaque. What they do is they put it in with radiography. They put a big catheter in and then deploy the stent. So these things are collapsed and then they deploy upwards. What they do is when they deploy, they actually have a balloon that it deploys them and basically elevates it. So when you're doing that, you're basically like internally cross-clamping and your blood pressure can go skyrocketing upwards. Okay? So that's why general anesthesia is kind of helpful at that point. You can just crank up the gas a little bit and get the pressure down, and when they do the deployment, the pressure doesn't really go up. There's not really afterload effect on the heart. Then as soon as they're finished with it, you cut back your gas and everything's fine. Versus regional anesthesia, you're sort of stuck. You're going to have to give something like nitroprusside or something during that period of time, which has its own risk. Now, here's what the deployment catheter looks like. See, this thing is actually opened up and pushing up against the stent. Okay. Well, what thing that they don't tell you too much about is that, and I sort of want you to warn you about this because it's happened here about a year ago, is that these things are supposed to recollapse back down. Okay? When they're finished with these things are supposed to be just the size of this diameter, not stay like this. And what happened was when they pulled this thing out, it got stuck in the iliac artery. Okay, and then they pulled it. And they pulled it too hard. And they actually ripped the iliac artery off the aorta. As you can imagine, that's a catastrophe in your hands. And the person exsanguinated on them and basically didn't survive. Okay? So you have to know that this is not a joke. Okay? Bad things happen with these stents. Most of the time they don't. Most of the time everything goes fine. The patient goes home in 2 days or the next day. Okay? I've actually seen some centers are actually sending these people as outpatients home, which I think is really ballsy, but who knows what we can do.